ASEP 20 is just around the corner. The world's largest emergency medicine conference will be held this year on October 26th through October 29th. Hear from leaders in the field, earn on-demand CME hours, interact with simulation labs and demos, network and socialize, and so much more. You can register for this must-attend virtual event at www.asep.org/ASEP20.
Ryan Stanton here with ASEP Frontline. Today we're going to talk about stroke, and that's going to be a theme for a few podcasts, but really now talking with a good friend of ours, good friend of the show here. She has been on our podcast a couple of times, Dr. Aisha Terry, and bringing us some of the information on stroke and then what has happened with regard to COVID, as well as some of the variations and variabilities we're seeing around the country and especially in certain populations, and how we can work with our departments and our patients to improve the overall care associated with stroke. So, Dr. Terry, thanks again. Welcome to the show, and tell us a little, give everybody, those that have not caught up with you before, a little background on yourself.
Well, thanks so much for having me, Dr. Stanton. It's a pleasure to be back as always. So I am Dr. Aisha Terry, practicing emergency physician here in D.C., Washington, D.C., at George Washington University, where I take care of patients, but also do a ton of health policy work. And in addition to taking care of patients at GW, I also take care of patients at the Washington D.C. VA hospital. So a bit of a variety there in terms of patient population. And given the topic that we're discussing today around stroke, I would be remiss if I did not add that early on in my career, the far majority of my research was actually in neurological emergencies and specifically stroke and TIA. I trained at University of Maryland in Baltimore, and while I was there, I did a fair amount of NIH-funded work related to stroke. So I've actually had my finger on the pulse related to this particular topic for several years now, and it's interesting to see how it has and has not evolved actually over the years. So it's a pleasure to be with you.
And once again, it's great to have you back. And I think last time I chatted with you was from LAC last year, back when we had in-person meetings, and so we look forward to that coming back soon. But that actually brings up the point of the podcast. It's one of the diagnoses where we like to say time is tissue, even though even that is getting a little blowback now with stroke. But the timing is integral, and one of the side effects that we've been seeing with COVID-19 has been significant delays in presentation and care. So, Dr. Terry, talk to us a little bit about just stroke in general, but really how we've seen a pandemic, COVID-19, impact stroke and presentations and management.
Absolutely. So, I would actually still argue, Dr. Stan, that time is tissue, and it's not necessarily directly always related to brain tissue per se, but we know that outside of the importance of recognizing stroke in a timely fashion, for the sake of decreasing poor outcomes, the reality is that the sooner we recognize stroke, we also see a decline in disability associated with that stroke. And so the thing about stroke is that we know it's super common. So about 800,000 strokes a year in this country. It's in the top three causes of death and disability, certainly in our country. And so outside of just recognizing stroke for the sake of recognizing it in a timely fashion, what we have to also really realize is that the sooner we recognize it, get treatment on board as appropriate, and also get treatment on board in terms of rehabilitation and making sure that the disability that often results from stroke is minimized is so important.
Of course, we've seen a lot of stroke presentations during COVID-19 as a secondary effect of the virus itself. In fact, many of our exposures in my hospital, where they send you that email that asks what kind of PPE were you in, have been actually stroke patients who came initially as a stroke and come to find out the hypercoagulable issues associated with COVID-19, mainly the immune response that increases that sludginess and wanting to stop of our platelets and blood. So talk to them about that impact of COVID-19 and the whys of why we're seeing, one, a potential increase, but two, the delays in presentation, people sitting at home for much longer than they should.
Absolutely. So COVID, just like it has wreaked havoc in every other area, certainly has done so as well relative to stroke. There was actually a study that came out of Wuhan, China, pretty early on during the pandemic. It was a study with over 200 patients from 3 different COVID-19 focused hospitals. And in that study, they found those COVID positive patients to demonstrate a third of the time neurologic manifestations of some type of condition related to a neurologic deficit. So a third of those patients had some degree of neurologic abnormality, many of which had stroke symptoms. And so pretty early on during the pandemic, we begin to recognize that in addition to the respiratory symptoms that we kind of consistently think of traditionally as being associated with COVID-19, that a lot of these patients were coming in with focal neurologic deficits that actually looked like, and in fact were, strokes, ischemic strokes. And so that was, I think pretty early on in the pandemic. And as we have proceeded over the course of the year, we've learned more about why we think that is the case. And we still certainly have a lot of work to do there. We do know that the neurologic manifestations could be due to actually, I take that back. I'm going to say we don't know whether or not the neurologic manifestations are due to direct invasion of the virus itself into the central nervous system, or if it's due to the effects of its systemic effects on the body, such as the hypercoagulability, neuroinflammation, as well as cardiac complications that can then lead to embolic events to the brain. And so it's unclear whether or not the virus itself is causing a problem with the central nervous system, or if the central nervous system is being hindered due to the side effects, if you will, of this virus, such as the hypercoagulability. Also, most studies are saying that it's due to the latter, that it's due to the systemic effects of COVID-19 rather than directly due to the virus itself. But I will say that there also has been a study that showed an increased risk of ischemic stroke in patients with COVID-19 compared to patients with influenza. So there's clearly a difference here. There's clearly something different, as we all know, about COVID-19, even when you compare it to other viruses, and that being relative to stroke and the development of neurologic disorder as well. And interestingly, the common development of anosmia, or decreased ability to smell, is really interesting when you think about COVID, because it suggests the possibility of the virus being able to directly affect the nervous system, given that the nasal epithelium is essentially the front door to the central nervous system. And so there's also a lot of discussion and debate and theorizing around the role of entry for COVID-19 into the central nervous system, and the fact that loss of smell and the nasal epithelium is so close to the brain. We have to consider whether or not there might be a connection there.
And I don't know that I've ever seen anybody that has come in with a stroke and then on the back end said, "Oh, you have the flu." Whereas, it's been a number, at least a handful that I've personally seen of strokes that have come in, and of course, pulmonary emboli as well, that have been associated with COVID-19. So there must be at least some, hopefully more than anecdotal type evidence that there is something that this virus is doing different. But of course, I think we've learned seen that not only does it present as everything it can do about anything, and likely is part of the interaction between the virus and our immune system, the two of them working together, one trying to take care of the other, and wreaking havoc as it goes through. But we've also seen a lot of times we've been involved with stories about decreased presentations to the hospital. We're seeing them coming in really late. I'd had an appendicitis case that came in 2 weeks after the onset of symptoms. We've seen increase in out-of-hospital cardiac arrests across much of the country, felt to be potentially from COVID, but more than likely from some of these delays in treatment. Why during COVID are these major? And I can understand minor stuff. I really don't, if I've got a cold or I stub my toe or whatever it may be, I may not want to go to the hospital when I normally would have because of the potential risks or concerns or thoughts about COVID. But why strokes? Why strokes and heart and MIs and things like that? Why are those not presenting like they would have before COVID-19?
Right. So again, excellent point. And, I think we were all pretty baffled early on in the pandemic when we saw that, in fact, we were not seeing strokes like we were used to seeing them. We were not seeing MIs like we were used to seeing them. Numerous local, regional, and national reports have shown that the rate of patients presenting to the hospital with acute stroke specifically has absolutely declined over the course of the pandemic. We're certainly seeing an uptick currently in those cases, but generally, people stop showing up, as you said. And so, the question becomes why. The obvious answer is that individuals wanted to protect themselves and not expose themselves to potentially catching COVID-19 by coming to the hospital, that people were actually adhering to the social distancing regulations and rules of their various cities and states. But as you said, you would think that something as pronounced as focal neurologic deficit on one side of your body, and perhaps even causing, difficulty with you being able to speak clearly, would prompt someone to come to the emergency department to have it addressed. I think to really get to the bottom of whether or not those individuals actually had those strokes at home and want delayed care and ultimately perhaps, unfortunately, may have expired at home, or if they just came in much later, remains to be seen. There's a huge opportunity to do large longitudinal studies to look at, pre and post COVID, if you will, or pre-COVID and during COVID, if you will, in terms of rates of strokes, so we can figure out, did we just miss them all? I can't imagine that suddenly the rate of stroke would just suddenly go away just because, we found ourselves in the midst of a pandemic. So it really is, in a lot of ways, mysterious. But there are definitely some studies being done to look into it to try to sort out what happened to all those stroke patients. I do feel like, in my opinion, we're going to see more and more, again, disabilities during COVID and post-COVID that perhaps we will ultimately be able to trace back to missed strokes. And I also anticipate the need for increased neurologists to manage the kind of aftermath of what we may have missed.
I want to roll into another area associated with stroke and how we can do better, and we'll wrap up with things we can do to help educate patients on presenting, making sure that they present or get checked out for their symptoms and everything else. But an area that I have talked with you before, including was about the diversity, inclusion, work within the leadership of ASAP and things like that. But there's also been significant issues within stroke care. And I'm actually going to quote from a 2014 article within the journal Stroke and Cerebrovascular Care. There are well-documented racial disparities in stroke. The rate of new or incident stroke in blacks is twice that of their white counterparts. Additionally, stroke mortality is higher in Black Americans. Gender disparities in stroke are becoming increasingly recognized, with a disproportionate burden of cerebrovascular disease among women. More strokes occur in women than men, a finding that is only partially explained by longer lifespan. And studies suggest that women present with more severe neurologic impairments are less likely to receive acute stroke therapies and have worse functional outcomes at 30 days, 1 year following hospitalizations. And also, women also receive lower quality of hospital care compared to their male counterparts. Talk to us a little bit about, kind of that pulling back the curtain of the disparities that we are seeing, and really, more importantly, the why. Why are we seeing that difference? We're aware of it, not just in stroke, but other diagnoses as well, and even seeing it in COVID. And I think, and we see the headlines about it, but very few actually dig into the why, the things that we can actually address and fix that start to pull these disparities closer to an equality that we would want to see across the board.
Sure. So again, super important concept and question. The issue around disparities in stroke based on race has been recognized for many, many, many years, actually back dating to the 1970s, looking at mortality statistics. And so this is certainly not a new conversation that we're having, unfortunately. I think the fortunate piece is that COVID-19 has discovered really stark, disproportionate outcomes for people of color in terms of COVID-19. And with that, some have certainly presented with stroke and other adverse effects associated with COVID-19. And so there's been just a huge magnifying glass placed on disparities and disproportionate effects during the pandemic, because you can't ignore it. I mean, when you're talking about, in some instances, 80% of Blacks being infected with COVID-19 relative to their counterparts, it's obvious that there's a problem here. I think in terms of stroke, when I actually I trained at University of North Carolina in Chapel Hill. And when I was there, I got involved with stroke care. And part of it had to do with the fact that North Carolina is a part of the stroke belt of the United States, meaning there in North Carolina, we see significantly disproportionate rates of stroke, not just amongst underrepresented minority populations, but in general, the entire population. And so the question is certainly age old, and I think that we have an opportunity now more than ever to hopefully address it in a more meaningful way than we have thus far. I will say that over the years, actually, the incidence of stroke has decreased across the board for everyone, which is awesome, and that's a good thing. But as you said, Dr. Stanton, we still have definitely the fact that Blacks are far more likely to have a stroke, and not just far more likely to have a stroke, far more likely to die from that stroke. The reasons as to why that disparity exists is largely placed upon increased comorbidities. And so based on the studies that have been done to date, the far majority of the blame in terms of that disparity is being placed on the fact that African Americans and Blacks have significantly increased rates of comorbidities such as hypertension and diabetes in particular, and that those two conditions are absolutely risk factors. And so then we have to kind of pull the sheet back again, as you mentioned, and say, well, why is that the case? Why is it that disparity exists in terms of having the conditions like hypertension and diabetes? And we think that a lot of it has to do with socioeconomics. It has to do with social determinants of health. It has to do with lack of awareness and education in those populations. It has to do with delayed care or lack of care, lack of access to care, lack of insurance. Has to do with lack of access to eating healthy, right? And so if you live in a neighborhood wherein it's very difficult to get fresh vegetables and fruit, then the only thing that you see is fast food, then certainly that intake of food will make your blood pressure go up. We know that sodium laden types foods. And so it's multifactorial for sure. And I think a lot of it really boils down to the social determinants of health. So that's one piece of it. And so when I say social determinants of health, I'm talking about educational levels and socioeconomics. Another pot is, again, comorbidities such as diabetes and hypertension. But I think we're also in an era now where we're recognizing that there's other things that are at play here in terms of worse outcomes for Blacks and people of color. And some of that has to do with on the provider side. In terms of the bias that we as providers, we as physicians actually might come to work with. Biases that are oftentimes implicit. In fact, the majority of the time they are implicit. And they actually tend to, without a doubt, be associated with poorer outcomes. There have been countless studies that have shown that implicit bias, first of all, is real, and that it, without a doubt, has been associated with poorer outcomes in terms of our ability to, one, listen to patients actively, to believe them when they tell us that they're having problems in various areas, and then to make sure that the treatment that we provide is equitable.
I appreciate that you brought up actually the point that is made in that 2014 study that I quoted, the Journal of Stroke and Cerebral Vascular Diseases, and they talk about the fact that one of the noted things that they demonstrated in their study was that that Black females, African American females, have a much more likely incidence of contraindications to interventions associated with acute stroke, and tended to have many times a later presentation of those symptoms. And unfortunately, I feel like so much of the media attention looks at just the physician provider aspect of it, that bias and differences in care that you talked about, but don't look at the more global picture, that access to care, the access to the education, the prevention, the risk assessment, those social determinants of health. We've actually done, associated with ASAP 19, we did 2 podcasts that were released late 2019, early 2020, on the social determinants of health and social considerations within medicine. So I suggest everybody take a listen to those, because there is much more to it than just a lab work or a vital sign or an intervention that we're going to do. There's so many more considerations that we need to make. So as physicians, how do we address these things? I think, looking at the dig in and getting into this very complex issue, disparities in care are not typically a single thing that you can point at and say that's the problem. It's a much more global net of things that come together, that Swiss cheese effect of a disaster that come together to have increased risk. And I've grown up most of my life within the stroke belt, within the Southeast, being Georgia, Tennessee, and Kentucky. And yeah, there is fantastic food that is terrible for you. And the fact that in the Southeast we love to fry everything, and we put more salt on it, and just the idea of sodium free is just not putting too much extra salt. And those types of approaches that we've had in this part of the country that have increased the risks of obesity, diabetes, hypertension, hyperlipidemia, stroke, cardiovascular disease, otherwise. How do we take those next steps as physicians to look deeper into this and do what we can to start to pull more people into the realm of better outcomes, better prevention?
Right. So, first of all, again, it is so complex. It's so multifactorial. One of the issues, in addition to hypertension and diabetes, very closely linked to the disparity in Blacks for stroke, is education. And so the lack of education. And so when I say that, I don't mean just decreased awareness around healthcare and what stroke is, but I mean a lack of general education, in terms of, grade school and even beyond, college and the like. And we know for a fact that decreased education is associated with worse health outcomes. Now, as a physician, we can't necessarily transform the educational system in this country, which I would argue there needs to be some transformation in terms of how we educate people and how we ensure that people are equitably educated. But what we can do as physicians is educate ourselves. So we can educate ourselves around the facts of the matter. We can educate ourselves around the fact that disparities are very much real, and also educate ourselves around the fact that we can play a role clinically, if nothing else, at the bedside in how we take care of patients. I think it's important that we recognize, again, our biases, and that we as individuals take it upon ourselves to do some implicit bias training on a regular basis. Because we have to realize that it's almost like CME, in the sense that in order to provide the most equitable and quality care to our patients, we need that training. We need implicit bias training so that we can recognize, the shortcomings that we have, even clinically as physicians, and how those shortcomings, many of which we're not even aware of, really, it's implicit, actually hurt people. It actually hurts people's lives, our patients' lives. It makes their outcomes worse. In some instances, patients of ours die. And so while bias is certainly only a piece of the puzzle, it is a significant piece Studies have shown, countless studies have shown that. And that is something that we can control as individual physicians. In addition to just being insightful around all of the social determinants of health, we should start with ourselves.
And to wrap it, or to put a bow on everything, and also I would encourage everybody to listen to the prior podcast that we had with Dr. Terry regarding the bias and the things that we don't see or realize when we walk into a shift on a daily basis. And actually, I did a talk for an EMS group about these different levels of bias, some conscious, some unconscious aspects of things. And it's really that unconscious aspect of bias that we have to really shine a light on, because we may feel like that everything is the same, and we may feel like that all things are created equal, but unconsciously there are some things that may push us off the right path. So being aware of that is going to be integral. With regard to COVID, and to kind of bring it all home, we've talked about the delays. We've talked about some of the disparities. We've talked about the presentations that we're seeing, the potential increased risk associated with COVID-19. What can we do as physicians and healthcare leaders to help educate the public in our communities and beyond, to help them understand that they need to seek care, that the time is tissue situation, that earlier is better, as we continue to move through what appears to be a pandemic that's going to be with us at least well into 2021?
Absolutely. So, I think that my area of interest again is health policy and advocacy for sure. And I think that aside from what we do clinically at the bedside, we as physicians have to own the influence that we also can have relative to advocacy. When you talk about advocacy and health policy work, that allows us to actually affect the masses in a really meaningful way. And so when it comes to awareness in terms of educating communities about COVID-19 and about social distancing and the like, then I think that advocacy is actually one of our greatest tools as physicians that we can utilize to, in a very meaningful way, impact outcomes. And of course, ASAP is doing a lot of work in the advocacy realm relative to COVID-19, in terms of really awareness, in terms of telehealth resources for patients in all parts of the land, right? And so the importance of supporting advocacy issues around tools that can help advance care in an equitable manner and mitigate the effects of disparities, such as telehealth. But in that way, we have to make sure that bandwidth is adequate across the land for individuals to be able to utilize it. We need to make sure that we, as physicians, are available and trained properly on how to actually take care of patients via telehealth and the like. So I think advocacy, and I just use telehealth as one example, is one way that we really can, as physicians, particularly collectively as physicians through organized medicine and through the college, can really make a significant impact in our communities and in terms of their outcomes and the like. And the other thing is, when we see patients in the emergency department, that's a huge opportunity right there at the bedside, to educate individuals on truth versus non-truth when it comes to COVID-19. Unfortunately, there have been countless myths and conspiracy theories circulating, particularly throughout populations of color during the pandemic. And I think I was reading a study not too long ago that said that many deaths actually have been associated with lack of information, misinformation, individuals believing myths and conspiracy theories, et cetera. And so there is definitely a huge opportunity for us as physicians to set the record straight, to clarify, what the truth is about COVID-19, how it's contracted, what the signs and symptoms of it are, how you can pass it on to other people, what the long-term effects are. I think I hear people talk about COVID-19 sometimes, well, not people necessarily that I hang around, but in general on the news or something. And they're like, well, if I get COVID-19, I think I'll be okay. And I'll just get it and get over it, and life will go on. But we need to educate people that the truth is we don't even know what the long-term sequelae are of COVID-19. So you really don't want to risk that, because while you think you might survive it, and you certainly may, we just don't know what things might look like for you in terms of your health down the road after having contracted this virus. And so, again, huge opportunity for us to educate and increase awareness throughout the community.
And I agree that you may be just fine. If you get COVID, there's actually the odds are in your favor that you're going to be just fine. But I think we need to put into context, how many risks are you willing to take that may have a small risk? I mean, how many times are you going to pull that trigger on that revolver of the Russian roulette of diseases and hope that one chance, or the 2 in 100 when it comes to COVID-19, doesn't come around? And I completely agree. We don't know. Everybody's rushing to have COVID parties, some are rushing to have COVID parties and things like that, back like what happened with chickenpox, but not knowing that, does it actually provide prevention? Does it actually protection and an immune response and everything that is necessary there? I also feel like as physicians and healthcare professionals, part of our job is public education and awareness. And this is an incredibly important part during COVID, our ability to battle misinformation, to help educate, to help put people on the right path. I mean, there's been enough changes and enough information and knowledge and learning through this that all of us have been wrong with at least one, if not 100 things with regard to COVID, but continuing to guide folks based on the current and best available evidence, and trying to keep people from going down the paths of some of this purposefully heinous and misinformation that is out there, and the clickbait that is out there, and the things that are just meant to get a political rise rather than any type of actual function to help protect people. And so the education, being a spokesperson, doing education around the communities, being available for media outlets to do those types of things. And then, as this evolves, continuing to move forward and to address our approach to stroke care, and helping folks understand, and to throw even another wrench into this whole situation when we're trying to get folks to respond and to get checked out when they have symptoms. I found out this last week of a person who had a stroke evaluation and treatment, admitted to the hospital, and then after going home, the insurance company reviewed that and said, well, there wasn't a clot on the imaging study, so you didn't have a stroke, and so we're not going to pay for any of this. And so we've immediately pushed that up to folks within the hospital, address the insurance company, but then also talking to our policymakers about the fact that our insurance companies are putting people's lives at risk in the name of profit. And I had somebody actually on a radio show this morning call back, kick back and say, well, maybe they're just not doing that for non-emergencies. I was like, well, I consider a stroke evaluation with intervention to be pretty serious. And sure, true. If it's truly a completely benign evaluation, something that was, what we consider a BS presentation to the hospital, a big nothing burger, whatever it is, then fine, whatever. But that's not going to be evaluation in time and resource intensive. But what we're seeing is these insurance companies kicking on abdominal pains, chest pains, neurologic-related symptoms, because they are high cost in terms of evaluation, but also high risk. And those are things that we can't allow happen. The patients cannot be deterred from presenting to the emergency department for what they feel is an emergent condition. And because at some point it could be, and some point it will be a significant life-threatening emergency. And the concern is that somebody's going to sit at home and say, well, I can't go, my right side is not working, but it may not be a stroke, it may be something else, and I'm not going to go because my insurance won't cover it, and I can't afford that, and all this other stuff.
And yet or I'll go, but I'm going to drive myself to the hospital because I don't want to pay for the ambulance ride, which I know is going to be a couple $1,000, which I can't afford.
Absolutely. And that's amazing how ambulance services, EMS services are always out of network, even though there is not actually one in network when it comes to most insurances. It's just an issue with this system. And as you mentioned earlier in the podcast, there's a lot that needs to be addressed with regard to the healthcare system in general. Some changes that need to be made no matter who is in office to actually get us moving in the right direction. So, Dr. Terry, how can folks, this is a huge topic. We will be back on this. Of course, we've got a few stroke-related podcasts this month. There's a lot of changes, as you mentioned up at the top of the hour. It's always a contentious conversation when it comes to stroke because of where the world is, where the technology is, where the treatments are, and that sort of thing. And I'm sure that's not going to change anytime in the near future. But what we can do is educate, encourage prompt evaluation, and do the best we can with the evidence that's out there. How can any closing words, and how can folks get in touch with you if they'd like to ask questions or more information?
Well, again, this has always been a pleasure, Dr. Stan. I appreciate it. I just end by saying that, while the topic of stroke certainly historically has been a contentious topic for some, I mean, the fact of the matter is that it is still a major source of mortality as well as morbidity in our country. It's right there in the top three. And so it can't be ignored, ultimately outside of decreasing the incidence and the prevalence of stroke, we have to think about how the long-term effects of our workforce, productivity of our country is being affected by these thousands and thousands of people who have strokes, sometimes early on in their lives, certainly, and why that is so important for us to get a handle on and try to address. I mentioned that sometimes folks in their early years have strokes. In fact, another interesting and sad statistic is that, for one study actually showed that the rate of stroke for Blacks under 65 years old actually was higher in some instances than some Blacks over age 65. And so that's interesting because we know traditionally stroke impacts people who are older. But when you look at subsegments of the population, particularly populations of color, we're actually seeing increased rates of stroke amongst some of the younger populations. And so, again, there's a huge opportunity to educate, increase awareness, make it clear that, anyone could have a stroke, actually, and that it's just about being aware of what signs to look for and to seek care immediately. And so I'd say just one more thing, and that is, just to kind of bring it back to the patient, which is always what we should do. I think as physicians, it's just so important that we meet patients where they are. And particularly when we're talking about populations of color, wherein the fact of the matter is historically, there have been instances in our country, certainly that warrant, not having full confidence even necessarily in the healthcare system. And I'm a part of the healthcare system. So I hate to hear that. I hate to say it, but it's true. And so when we're talking about reaching populations of color and trying to mitigate once and for all these really unnecessary disparities that we're seeing, we have to meet patients where they are. There's a community project going on in D.C. that some physicians put together wherein we're going to Southeast D.C. and we're going to be walking with residents of D.C. It's called Take a Walk with the Doc. And, I think to just, again, meet people where they are, go into their communities, right? And show that we really do care, that we really want to better understand their situation and their circumstances goes a really long way. And so I'm actually going to be participating in this Walk with the Doc program, wherein we're just going to walk with residents of that community, which is largely African American, and providing just some basic information, education. And while we're doing it, we'll be getting some exercises in. And so once we, I think, are intentional about keeping those lines of communication open and clean and fair and honest, we'll see change. They can reach out to me at aterry@acep.org anytime.
All right, Dr. Terry, I really appreciate it. And I think there are plenty of steps that can and should be taken moving forward with regard to stroke care, education, advocacy, continuing to evolve the treatment opportunities and availability, and really trying to decrease the toll of this very serious diagnosis and process. And working this weekend with a physician who had a posterior circulation stroke, very young age, and that benefited from the evaluation, the interventions, and the treatments that have put that person back at work and functioning and in full force. It's been huge, and we want everybody to have that opportunity based on their diagnosis, decreasing those risk factors, but also getting evaluated as soon as possible. You can contact me at youreverydaymedicine@gmail.com, youreverydaymedicine@gmail.com, or at everydaymed on Twitter. I also encourage everybody to not only subscribe to the podcast on whatever platform you like, but share it as well with others, with your friends, with your colleagues, and occasionally with the public, because we have some public offerings coming out here and again. So, including one that is going to come up in a few weeks regarding the legal aspects associated with COVID and hiding COVID diagnosis. So, you want to stay tuned to that? Please share it. Encourage your friends, family, whoever it may be, to tune into the podcast as well, because we have the opportunity to talk with wonderful physicians out there, wonderful healthcare leaders, those like Dr. Terry and many others. So I appreciate you tuning in, and until next time, I'm Dr. Ryan Stanton, and this has been some ASEP Frontline.
And in the sun